everyone, my name is Kendrick. I'll be giving you a brief presentation on my project, my master's project today, which will be the comparison of the dose to the eye lens during radiotherapy of the nose with brachytherapy, VMAT and electrons. And I would also like to thank my supervisors, so Pedjamin, Martin, Joshua, Mashid, Talat, Alicia and Ryan. There's a big list of them there, but thanks everyone. Okay, so what's involved in this project basically? Well, 10 patients already treated with volumetric modulated arc therapy for skin cancer of the nose will be retrospectively selected. The patient data will be provided by Charlie's, and my aim will be to utilise radiochromic film to calculate dose distributions for 3 different treatment modalities. And basically this leads into the 3 sort of key aims of this project. The first one being to create a 3D dose reconstruction using film techniques for the ocular region for each of the treatment modalities. Secondly, to compare that 3D dose reconstruction to the treatment planning system dose calculations and see how they match up. And finally, if I can, determine which method results in the minimal lens dose. And this leads to sort of a map that I will be following for this research project. The first of all was the literature review, which is done. That's got a nice little tick next to it. Secondly, I'm going to be learning the treatment planning systems, the 3 of them that I'll be utilising in this project. So that's Brachyvision, Eclipse and Exio. Then I'll aim to create clinically deliverable plans using those treatment planning systems, whilst ensuring adequate tumour coverage and also minimising the organ at risk dose as well. And those will be delivered to a 3D printed ocular structure, which will have spaces in it for the film to slid in. And of course that ocular structure will have to mimic the electron density of the real human eye so that we can mimic the dose distribution characteristics that would occur in a real human being. Following that, I'll need to calibrate the radiochromic film as well in order to create a calibration curve like you see on the screen there. So the aim is basically just to relate a particular optical density to a dose so that once we scan the films we can get a pixel by pixel distribution of the doses once it's been scanned. And then yeah, those plans will be delivered to potentially a custom-made phantom with the 3D printed ocular structure inside and the calibrated film of course inside for the measurements as well. And then following that there'll be a creation of a 3D dose reconstruction by using MATLAB code, by interpolating between the film locations and attempting to do it that way, so that we can then undertake the 3 main aims of comparing the film dosimetry with the treatment planning system dose calculations, ascertaining which treatment modality minimises the lens dose, and if there is time at the end, we will perform some experimentation with shielding techniques for the eye as well to see if there's a particular combination of materials that is most conducive to reducing the dose to the eye lens. Hopefully that results in a publication. So, what is nose skin cancer? Well, basically it's separated into 2 groups. So you've got non-melanoma skin cancer, which is the most common by principal diagnosis in Australia. And that itself is divided up into 2 separate categories. We've got basal cell carcinoma, which accounts for about 70% of non-melanoma skin cancers. And you can see these there at the bottom of the epidermis, which is the top layer of the skin. So that's basically where the tumour originates. Similarly for squamous cell carcinoma, which accounts for the remaining 30%, that originates in the squamous cells of the skin up here, so the sort of top of the epidermis there. And that's non-melanoma skin cancers account for about 1/4 of all cancer-related hospitalisations in Australia at the moment. Second group is melanoma skin cancer, which, as the name suggests, means the tumour originates in the melanocytes, which are just here on the screen. They're responsible for the pigmentation of the skin, and together these 2 categories, or skin cancer in general, accounts for about 80% of newly diagnosed cancers in Australia, so it's a pretty significant percentage. So how do we treat it? Well, surgery remains the modality of choice. It's still the gold standard. Avril and his colleagues performed the only thus far conducted randomised study of basal cell carcinoma of the face comparing radiotherapy and surgery. Primary endpoint was local control outcomes, secondary was cosmetic outcomes. They randomly allocated 347 patients to either of those 2 groups. And what they found was that for both of the endpoints, surgery was actually better. So it had better local control outcomes and also cosmetic outcomes. And they were assessed by the patient themselves and also independently by a few people involved in the study. So surgery is still the modality of choice, but when it comes to the nose, sometimes surgery is not a viable option. In certain locations, it's difficult to perform surgery without resorting to consequential grafting and reconstruction procedures. And additionally, some sections of the nose are actually easier to access surgically as well than others. So for example, the upper lateral areas and the bridge are a bit easier to perform surgery on, whereas the lower parts, so the alar and the tip, are actually more difficult to perform surgery on just because of the natural contours of the nose. So this leads us to the radiotherapy aspect side of things. The first one that I'll be analysing is brachytherapy, and just a brief overview of this. It's basically when the tumour is exposed to radiation resulting from the decay of a radioisotope, either inside the tumour volume or in its near vicinity. It's usually delivered through an individual surface mould of water equivalent bolus, and the radioactive source travels through catheters and delivers the dose that way. There is a new type of brachytherapy called electronic brachytherapy, which utilises small X-ray sources rather than the radionuclides, which has potential to reduce a lot of accidents that occur from transportation and setting it up in the clinic and that kind of thing. So a greater safety outcome. But at the present moment in time, the source size is too large for it to be suitable for treating skin cancers of the nose, so it's not used at the moment. And when you're thinking of brachytherapy, you're looking at about 97% local control outcomes. At least that's what Crook and his colleagues found when they analysed interstitial iridium 192 in the treatment of external nose skin cancer, and good or aesthetically acceptable cosmetic outcomes in 82% of patients as well. So the second one is volumetric modulated arc therapy, which, as Yutong said, essentially builds on intensity modulated radiotherapy. It's delivered on a conventional linear accelerator with a standard multi-leaf collimator, and that essentially allows it to modulate the intensity of the beam according to the requirements of the target volume. And the machine also rotates in a 360-degree arc around the patient as well, allowing a highly conformal dose to be delivered. It can also reduce treatment time as well in comparison to IMRT, which is important. Briefly with electrons as well, in this case the tumour is irradiated with energetic electrons. It is also delivered on a conventional linear accelerator, but the removal of the tungsten target just allows the electrons to continue on and instruct the tumour that way. And when you're, something's on the screen. When you're looking at electron therapy, Van Hesselwyk and his colleagues found that after analysing 434 skin cancer patients, depending on the total dose and the fractions used, you're looking at about 96 to 98% local control percentages, and also good or fair cosmetic outcomes, either 100% or 74% of the time, depending on the total dose and the fractions. So what then is the significance of this project? Well, as I said before, non-melanoma skin cancer is the most common in Australia by principal diagnosis, and it also accounts for the second largest cancer expenditure of the Australian healthcare system. And it tends to develop in areas that are exposed to the sun, or skin cancer does. So nose is one of those, back of the hands, ears as well. But the problem is, when you're treating these with radiotherapy, it's difficult, nose skin cancer in particular, it's difficult to avoid irradiating structures of the eye. And the lens is a very radiosensitive part of the body, which I'll get into in a minute. As we know, vision is a fundamental aspect of human life and well-being, and the purpose of us in the medical discipline is to treat the tumour whilst maintaining as much as possible the patient's quality of life. So if we can potentially minimise the dose to the lens in the clinical setting when we're treating nose skin cancer, then that's a step in the right direction towards achieving that goal. Additionally, we also know that the treatment planning system actually shows inaccuracies when calculating doses at the superficial level of the body. So Aquino and his colleagues actually compared GAF-chromic film measurements to the Eclipse treatment planning system at various depths, up to about 11 millimeters. And what they found was, at depths less than 6 millimeters, the film measurements were between 12.1 and 9.1% higher than the treatment planning system calculations. So what that means is that there is a possible consequential underestimation of dose, not a yellow alert, that's occurring when we're utilising the treatment planning system calculations to calculate the dose for the lens, which is located about 3.2 millimeters in the body. So it's within that range where those inaccuracies occur, at least in comparison to gaff-chromic film. So what is the lens then? It is an avascular and highly radiosensitive tissue of the human body. Basically, its function is to focus light rays that are incident on the retina, incident on the eye, onto the retina, which are then converted into a neural signal for the brain to interpret as an image. And as I just stated, it's located very superficially in the body, at a depth of only 3.2 millimeters. So it's within that range where we would expect that these treatment planning systems are showing differences with gaff-chromic film measurements. So yeah, that's an important consideration to take into account. An exposure of the lens to radiation can actually cause cataracts, which is essentially just an opacification of the lens, which impairs vision. Glasses can help this in the early stages, but the only long-term option for treating this is surgery. And its incidence is increasing. So if you have a look at this graph here, its incidence is definitely increasing, and you're looking at hundreds of thousands of hospitalizations as a result of cataracts every year. This is just in Australia, so it's, yeah, it's not inconsequential. Now, the dose constraints. Well, the ICRP, publication 118, is the major scholarly source summarizing the dose information. And what they conclude is that it is one of the most radiosensitive parts of the human body. Detectable opacifications occur at exposures as low as 0.5 gray, which is in dramatic contrast to the rest of the body. It's about 5 to 20 gray, they state, for the rest of the body, where you can get detectable changes. And what they concluded was that their previous threshold dose of 2 grays was actually significantly too high after they reviewed the most recent literature. What they found was that the early studies they were looking at had very short follow-up periods. So the lower the dose you expose the lens to, the longer the latency that the cataract actually develops. So these studies that had short follow-up periods were actually missing late developing cataracts that resulted from very low exposures, such as 0.5 gray. So they changed their threshold dose to 0.5 gray, and that basically just means that there's a 1% incidence of cataracts if it's exposed to 0.5 grays. And in the clinical scenario, this is significant because the lens is usually delineated with an OAR constraint of about 6 grays. So we could be getting consequential amounts of cataracts forming from this. What sort of process it is, there is no consensus in the literature. So it could be a stochastic process whereby the damage of a single epithelial cell then goes on to divide, and after a certain number of cells are present, you then get a clinically detectable cataract. Or it could be a more deterministic process where it takes a certain number of actual cells to be damaged before it's registered. But there is no consensus in the literature on that one at the moment. So, are there any studies in the literature comparing these treatment methods to each other for skin cancers of the nose? Well, the answer is there are a few, but none of them actually use any dosimetry to compare them. So none of them use gaff-chromic film. Okay. And they all use the treatment planning system dose calculations in order to compare the doses. So Kunkman and his colleagues compared high dose rate brachytherapy to photons and electrons for skin cancers of the earlobe and nose. What they found was that the 10 patients they analysed, the planning target volume receiving 100% of the prescribed dose was greater for brachytherapy than it was for external beam radiotherapy. So it was a bit more coverage of the tumour, I suppose, for brachytherapy than there was for the photons and electrons. Additionally, they also found that the high dose rate of brachytherapy spared more healthy tissues of higher doses. So the volumes of tissue receiving 70%, volumes of normal tissue I should say, receiving 70% and 90% of the prescribed dose were less for the brachytherapy than they were for electrons. Weinberg and his colleagues performed a similar analysis, except just with high dose rate brachytherapy and electrons, and only for skin cancers above the clavicle. It was 8 patients who were all treated with HDR brachy with electron plans created for comparison. They found, very similar to Kunkman and his colleagues, that the electron beam resulted in more normal tissue being or receiving between 50 and 100% of the prescribed dose. But interestingly, they found the opposite, that the electrons provided a more uniform dose coverage than brachytherapy. And finally, Willett and his colleagues compared high dose rate brachytherapy and electron therapy for skin cancers of the face. 99 patients were retrospectively selected. They focused mainly on local control rates, and they found that brachytherapy had 100% local control rates, electrons 98.7% after a 13-month follow-up period. And you can't see it, but the toxicity is less than 5% for both.
Press the stop.
Oh, what's that? Sorry?
Click on the stop sign.
Oh,
Yeah,
okay. All right, cool. Cool, so what's next, basically? Well, if we jump back to the research map, next up is just going to be familiarising myself with the treatment planning systems, so Brachyvision, Eclipse and Exio. This will probably be after exams, but that's next up on the list. And yeah, thank you everyone for listening. Sorry for the annoying announcements.
It's fine, my hospital just went internal.
Yeah. Any questions?
Oh yeah. There's one radiotherapy technique that was missing. Do you know what that is?
One radio, would it be protons?
Oh, that's another one. But one that's commonly used in this site.
Oh, okay. I'm not too sure.
So like superficial X-ray.
Oh, okay. Yeah, superficial X-ray. Yeah.
So, do you think that'll be a limitation? Like, because that's commonly used.
Okay.
In these sorts of treatments. But
Yeah,
we don't
yeah.
have it here. So,
Yeah, well, it definitely would be a limitation. Yeah, if I wasn't able to analyse those as well. If we don't have it here,
Yeah.
it's very difficult for me to do
Definitely.
that. But yeah, if it was here, I would certainly think about it.
yeah, probably just something you want to review a little bit.
Definitely. Yeah.
It's quite ambitious what you're planning.
Yeah,
to do.
it's
So there's quite a lot
very broad.
involved.
Yeah.
If you had to prioritise it, what would be a reasonable outcome?
I think
that's a subset of all that.
Yeah, I think probably the main thing is to create those 3D dose reconstructions. If we can do that, we can compare those to the treatment planning system calculations and see if they match up. We're mainly focusing on the lens, so if I can do that for the lens, that's the primary outcome, I suppose. It can always be extended to other parts of the eye. You know, there's obviously a lot of other critical organs in the eye that need to be considered. But that is what I would say would be the main focus, so the 3D dose reconstructions, performing that. And also just doing that for the lens and seeing which of those methods minimises the dose for the lens.
What if you had to focus on just one of the treatment methods, which would be the most important?
Oh, on one of the treatment methods? Well, I'm not really too sure if I just had to focus on one of them. I guess the whole project is more about comparing them and seeing how they match up. I think I would probably focus on the brachy. The reason being, there are a few projects, a few pieces in the literature that say it spares more healthy tissue of higher doses and seeing how that compares with the lens dose. But I guess the whole project is really about the comparison, seeing how those treatment modalities match up with each other and how they minimise the lens dose. So I couldn't really focus on one, I guess.
Have you, and I know it's a little bit further down the track that you're looking at making your model of the eye, thought about were you planning on sort of layering the film through the lens sort of to it, or was it more an ant to post sort of going deeper?
So I suppose the idea was to 3D print a whole ocular structure, and we know where the lens is in that, so we can, we know it's at about 3.2 millimeters. We can organise the film arrangement so that they sort of match up with that, but then with the 3D dose reconstruction, we can hopefully get the dose to the whole ocular region anyway, so we'll be able to calculate it for the lens. And I'm not sure exactly what sort of spacing, there'll be in that sort of structure at the moment. I haven't really thought that far ahead, but yeah, that's sort of the idea at the moment. Yeah.
And are there shielding options that you could try?
Yeah, well, with the shielding, Pejman and I were talking about doing some Monte Carlo code to see what the best sort of shielding is. That was sort of placed as a second priority. like towards the end of the project if I get time. But yeah, absolutely, there is definitely some room to test out which shielding options would be the best. Running some code to see what would come out, definitely.
In the correct superficial.
Oh, okay.
I think maybe you just answered it, but my question is, do they have any patient protection currently when they're having their treatment on their nose? Like, do they wear like their glasses or any protection for their eyes when they're...
As far as I know, not really. No, so there isn't any protections at the moment. That was the whole purpose of running the code, sort of towards the end of the project, to see if there is any combination of materials that would minimise the dose there. Because I think Benjamin and I were talking the other day, and with the lead, it sort of creates even more electrons that then go on to produce a dose in the eye, which is counterproductive. So, but something to look into for sure. Yeah.
At the moment we do have for electrons we do use shielding. It's not about we have different doses, but depending on the energy we do use for electrons. For brachy, it has a main use, but it's good to use.
Great.
Good luck.
Thank you.